vamos a dar el paso a la mesa de encefalopatía hipóxico isquémica. En esta mesa vamos a estar coordinando la doctora
Dr. Carolina Serrano, who is my colleague and friend, Dr. Carolina Serrega, who is a neurologist, pediatrician. She is a professor of fetal neurology. She is a member of the academic committee of Encefalopatía, and me, Richard Vaquero, and I'm a nephrologist, a pediatrician. I work in Medellin. I'm also a member of the scientific committee of Alcebneo, and we are going to talk about, and we're going to have two very special guests. Carolina, who are we inviting, Carolina? And in neurology, we have Dr. Cesar Sanchez, that it's running away. And the ones that know Cesar, please remember he is a neurologist, pediatrician. He focuses and also encephalopathy and we also have, because one of the missions of Alcebneo is also very important to talk about the guideline that it's the disciplines, the different disciplines. We also have Andrea Perez. Andrea Perez, it's a nurse from she's a magister of Universidad Católica, and she is a candidate to psychopathology and development in Chile with ample experience in the NICU in Buenos Aires and several important centers that have a lot of clinical experience, and she has had several publications, and she's a member of Alcebneo. I'm also going to be there as the moderator, and I am okay, we're going to move forward. And first of all, we would like to make a very strong add to the guideline that has just been published and by Alcebneo. This is a very special guideline because it's a multidisciplinary guideline. You are going to have access to some areas to some different segments of the guideline, and there are different disciplines talking about prevention, diagnosis, management, and follow-up of hypoxemic encephalopathy with all kinds of content. It's a jewel because not many guidelines combine so many voices speaking about the same topic. Right now, we're going to give you some very interesting data about the hypoxico-ischemic encephalopathy, and we're going to do a clinical case. Why is it important to talk about neonatal asphyxia? Because it's common, because it's serious, and because it keeps on happening. More or less 4 million deaths at the global level are done because of hypoxemic encephalopathy, and most of this happens because of prenatal asphyxia. This is the second cause of, it's the second world cause of burden of the disease. And in children under 5, we can see that this not only causes death, but the survivors, it's still a cost not only for the system, but also emotionally for the families. And we currently have a very important, significant equality gap, and I think it happens in most of the pathologies, both simple and complex pathology, and compared to the other parts of the world, especially North America and Europe. In the high-income countries, we can see that there is an estimated 1 to 2 cases of asphyxia per 1,000 born alive. We're talking about systems where the prenatal system works really well, and the home deliveries that don't exist or are very well monitored. The mortality, it's more or less 20%, and we can see that the clinical approach, it's done with the neurocritical care, including hypothermia therapy as the standard therapy, where there is no doubt, there's no doubts regarding the bibliographical references in Latin America. We have an incidence that we believe that it's higher, and I say we believe because the information is rather heterogeneous. It depends on the complexity of the care centers where we take the information from and what's the definition that we grant the pathology, but we think that it's more or less 520 cases for every 1,000 born alive. We say that it's more than 10 times. It's 10 times higher than the areas where knowledge is produced. We have a lot to say. The mortality is higher. It's more or less 55%, and the clinical approach patient, it's higher, and it's also a reality that we lack resources, that we lack a technology, and of course we lack a follow-up that it's well structured. As Hebneo by Cesar Sanchez did a survey between affiliates and non-affiliates to try to do a stratification about what happening in our Latin American reality, and we had a scope of 119 neonatal units that were surveyed throughout 16 countries. The complexity levels of the units of those people that answered the survey was more or less 50%, and therefore we can say 17% and 33% level 2, and therefore it's better. The thing is that when we see it's that there's a representative perspective that reflects that most of the mid and high complexity centers operate with limited resources. And if you would like to have more data of the survey, you can read this when you download the guideline. There's a very significant part talking about the survey. We're going to talk about in a clinical case. What we wanted to show you, it's a classical case, a typical case, an everyday case, and we're going to try to have a very comprehensive care of this baby, and we're going to see it from the perspective of nursing, neurology, and also nephrology. The three perspectives: we have a male baby that is born at 39 weeks, and it's a first pregnancy. And the C-section, it's the mother, it's done an emergency C-section because during the intrapartum, and they identify a sustained fetal bradycardia. That's why they considered this as a non-reassuring fetal status. He doesn't respond to resuscitation. That's why they do a C-section. This baby weighs 3,120 grams. He is 50 centimeters, cephalic perimeter 33, and the ABLA score it's 3 at minute 5 and 7 at minute 10. It's like it's a real life case. We decided to take the gases from the umbilical cord with the adequate technique, and we identified that the pH is 7, the excess base is -18, and the HCO3 it's 12. Upon neurological examination, what it calls the people's attention when he's being resuscitated, it's that the patient, after being resuscitated, intubated, has bradypnea, has a global hypotonia, and absence of suction reflexes, and the pupils are reactive but slow. And although he tried to cry, and his crying was weak, and we can see that the heart rate was 102 beats per minute. He's a bit pale. There it's bleeding by the cord, and there's some reactivity with the nociceptive maneuvers with discomfort phases, but it's not. But this response, it's not sustained. It's just a reactivity. That's why we are going to start talking about the critical care, and we're going to give the floor to Dr. Cesar so that he talks about what is his first approach, what is his going to, what will he tell us about the staging of encephalopathy. In this from my perspective, for be able to develop to see what it's an hypoischemic encephalopathy, and we are going to discuss the advantages and disadvantages, the limitation of each one, and therefore one observation is that Dr. Sarnat didn't describe the scale to determine encephalopathy during the first 6 hours, number one. Number two, and therefore the original scale was described with 21 cases. Number three, we can see that this is a scale done to assess throughout the days the dynamic evolution of the and therefore of the hypoischemic encephalopathy. It was defined as stage 1, stage 2, and stage 3, and the 21 children that were admitted went through staging number 2. And also we can say that this is a scale that was never replicated. In another cohort, the Thompson scale, it's a scale that has some scoring, has some numbers, but the truth is that it's not a scale that were done to diagnose it during the first 6 hours. It was done through time. We can say that a Shankaran or the Shankaran scale during our first approach had a very significant failure. That was that they were not able to define nor the patient with mild encephalopathy or the patient without encephalopathy. They only defined the patient with moderate and severe encephalopathy, and that's why to say that it's not moderated or it's mild. It's a very wide gap, and that's why currently the studies that are being done in the United States are going to end up saying that we need to cool down the milds. No, we need to see what does mild mean. Something that I don't like. Something I don't like about this current trends. It's that mild. It means that you can have two mild criteria, two moderate and two, but not more than three for moderate and severe. First question: did you understand what I said? I know because I didn't get it. I had to read a lot. You're very smart if you got what I said. But what I don't like about this deficiency is that you mix items for all the categories and you don't exclude them between them. And for me, the most important thing that it's done for the diagnosis during the first 6 hours, it's the Garcia-Alex scale that it's done for, that has a prognostic values during the first 6 hours, that it's associated to the alterations in the MRI and their adverse development. And we can see that the disadvantage the fault is ours, the blame is on ours as the users of the scale, because we haven't published more extensive studies to be able to confirm and to support that this scale works. This is something that we've talked about Fundación N, and this is as fans of Dr. Garcia Alex, we haven't supported the scale, but this scale it's done for this. Okay, from in nursing and a patient with prenatal asphyxia, what we do is we need to take into account the temperature control when this patient, when we require that this patient goes to therapeutic hypothermia. That's why temperature control the care of the skin. And regarding about how we use the device, how are we going to place that neonate in the position that it's required, because many times we have this idea that the baby has a therapeutic hypothermia and I can't touch him, I can't rotate him. However, there are devices and there are ways in which we can take care of the skin of that neonate, and we can change the support positions if it's a neonate that has a high instability. And we can see that the management of the medication is very important, because we can see that in neonates and also in critical episodes where there is a medical emergency is where the highest medication errors take place. That's why we need to take into account how we manage that medication, the five correct elements required for the administration of medication, and also the management of comfort and pain prevention. We also need to be very careful, because one of the questions that are usually done by the nursing team is, are we cooling the baby down when we are cold? We feel discomfort. What is that neonate feeling when we're cooling him down? And please remember that neurodevelopmental care, we are going to take the neonate to therapeutic hypothermia, thinking and improving the neurodevelopment, but we also need to take into account the care that we provide despite hypothermia. How will that influence the neurodevelopment? If, for example, this is part of the guideline that I invite you to read, and how to adapt the environment of the NICU to this neonate, because sometimes one has the bias that if the patient is in therapeutic hypothermia, we need to cool him down, and we only think about that in the temperature control, and we forget that there is the environment, the temperature that can interfere in the time that it's required, that we start reducing the temperature of the neonate in the lightning and the sound, not only to think about the prematures, but the influence of light and sound in this type of patients, and the access and the organization of the devices. The ideal is to have devices or teams that are trying in the therapeutic hypothermia, that they're specialized, and that we can train the medical and nursing teams. For example, in Chile, we have the nursing teams. In Argentina, we don't have the nurses do all the procedures. That's why the ideal thing is to have a trained team where they are being updated with the new guidelines that we have regarding this, and other things that we need to take into account are the model of care. If the neurodevelopment not only means the neurodevelopment of the neonate, but also the care, also the cares of the neurodevelopment care associated to family-centered care. Remember that these are parents that are expecting a baby that it's born at term. However, they're expecting a healthy baby, but they find a very different picture without knowing how it's going to work out. This is very important because part of the things that I like about this guideline in this symposium, it's that the hypoischemic encephalopathy, it's not the whole brain. And even if we could have an academic conference only for hypoischemic encephalopathy, I feel great because we are interested in the kidney. The kidney is important, but it's important to clarify that when we talk about hypoischemic encephalopathy, that are going to allow us to be able to identify an acute kidney lesion, and that's void that we have during the first 48 hours of the creatinine, that it's a value of the maternal creatinine, and we've been known this for a long time. However, currently we have described the different ways through which we can detect the way in which the kidney is being involved, because more than having such a it's not a brain disease, it's a systemic disease that involves the kidneys and all the other organs. This is a multisystemic disease. One of the first recommendations in the guidelines, can check it out. It's the Gupta recommendation, that what it does, it's that we need to take into account the initial value of creatinine in a patient, and between the first 3 and 7 days, we can have descent between 37 and 46%. It should be the expected descent in the context of a patient with an HIE compared to an acute kidney lesion. On the other hand, we have biomarkers. However, we know that given the limitations that we have, they are not available, and that's why in Colombia we have the system in C, but we don't have it even in need, some procedure that it's called MIPRES, but we also have it available within the NIDU, that they have other markets, but the costs that are associated to the use of this biomarker, it's important to take into account when we talk about healthcare systems. That we need to take into account the diuresis of these patients, especially taking it per kilo per hour during those first 6 hours, because we have a patient that, despite even having a normal diuresis, this doesn't mean that they can't be kidney involvement. And remember that 60 and 80% of the patients with HIE have a very important involvement in the kidneys. In this table, I'm not going to discriminate or divide and say it step by step, but the important thing is that the kidney, it's a sensor of the hemodynamics of the patients with HIE, and that the hemodynamics of an HIE patient, it's key to avoid a higher neurological involvement. That's why to have a patient that is hydrated with a very good volume, and also with constant and with adequate control, it's going to allow that the hemodynamic control, it's done in a better way. And within this context, we have patients that we already have in an ICU, and there it's a role that all of you fulfills in this ICU. And the role of the neurologist, it's important, of the nursing and neurology. Neurology, tell us about the role of neurology in this. Yes, next. And I think that something that is very important for us, something important is when we talk about neurology and neuromonitorization, something very important, it's the early identifications of epileptic seizures. And having said this, we can see that with this new classification, and this is not new, and in 2017 to 2021, this classification was published. We need to understand that something basic to understand this crisis, it's to have a neuromonitorization. It doesn't matter, but we need it, and this is an issue in our context. And another important thing that I want to leave you with in this slide. It's that the clinical assessment, number one, it's that based on this assessment, there's no generalized tonic-clonic seizure. They all tend to be focal seizures because we've done very extensive studies, and all the crisis or all the seizures are focals. Maybe they're bilateral, but at its onset they're focal. And if you check out the first cause of these types of crisis, it's still HIE. And we can say that the brain monitoring, it's going to help me to be able to identify the crisis. It's also going to allow me to establish a prognosis. And what we have seen throughout time, it's that the evolution of the trace of the integrated amplitude electrode through time has a prognostic meaning. And as we can see on the graph, if a kid starts with an abnormal trace, doesn't mean that he's going to have a poor outcome. What gives me the prognosis, or how the prognosis works it's that if I keep on that abnormality within time and I'm abnormal at 48 hours, then in the study that we did, there was an 80% possibility of having an adverse outcome. Hey, but however, I was talking with the Swedish doctor, and she was asking me, what is an adverse outcome? For me, this is an adverse outcome, a moderate disability, a very severe disability, or death, because for many protocols, the success is in the survival, because a moderate disability in our environment, it's not easy. For me, a moderate disability, it's an adverse outcome, and that's why we can see that if an abnormal trace between the 36 and 48 hours, the positive predictive value was 80%. If that abnormal trace prevails between 48 and 60 hours, the positive predictive value for an adverse outcome was 100%. And we cannot say that it's altered during 72 hours. So this part of that neuromonitorization, it's the early detection of epileptic crisis and the effectiveness of the anti-epileptic treatment, but it's also associated to the long-term prognostic value. And I hadn't shown this slide, but I'm going to finish off with what I was telling you. What do we propose? What can we do? Neuromonitoring. It for me starts with the HIE, with the assessment of HIE. That's a clinical way to do some neuromonitoring. Then we can have some. If I have an electrode, I need to start when I know that that patient is going to go into hypothermia, and he needs to be monitored for 72 hours. And we can do image neuromonitoring. If there's no hypothermia, is it worth to do serial Dopplers since the first days, the first 24 hours? And if there is hypothermia, we need to remember that when they're more sensitive to these tests is between 3 and 7 days is when I should do the assessment of these children, as stated in the guideline. And something very important, it's that the fact that they're not hypothermic doesn't mean that there's nothing to do. You can do a protocol normothermia, and you can do the follow-up, and you can do the labs of these kids and avoid hypercardia, hypoglycemia, and avoid hypoperfusion. And all these protocol, as Richard says, has a multi-organic repercussion, and because we need to take care of all the organs of the kids with HIE. As they already said, most of us don't have hypothermia. When we talk about nursing care, how can we from the nursing team prevent adverse events? And here what I did was to generate a very fast guideline of the main concepts associated to the thermal management, and to know that the overcooling, it's also harmful for the baby, as well as inadvertent hyperthermia. This is when we are in the warming of the neonate, when the when the therapeutic hypothermia period finishes. And we request that neonatologies have protocols and that all the team that is managing this type of patients knows and it's aware how they should heat or reach the normal thermia of that neonate. Continuous monitoring. It's essential that the nursing team with these types of patients as well as with severe patients pay attention to warning signs. Dr. Cesar was talking about the expanded EEG. The thing is that all the team is able to identify seizures because sometimes the doctors are outside the unit and we also only have the nursing team, and if one is not aware, there is a risk for the neonate. That's why the update needs to go hand in hand with the care of these type of patients. And if we don't have an expanded EEG, the control of vital signs in ears, the control of glycemia, the identification of the hemodynamic instability is very important, also associated to skin care. And when the patient is therapeutic hypothermia, there is a more risk of subcutaneous necrosis that is associated to the risk of hypercalcemia. And to be able to identify those nodes, it's important for the nursing team, and this is associated to the comprehensive control of neonatology. And okay, I said this at the end, but it should have gone at the beginning, along with thermal management, which is the management of pain and comfort. We need to have assessment protocols. Pain in neonatology, it's something that we need to work upon. We still don't have validated scales in Spanish. We don't have many. We don't have standardized protocols where all the units say, okay, we are going to use MPAS, we're going to use PIP-R. Besides, we need to take into account that these scales are not validated for this type of patients. Most of them are validated for premature neonates. That's why I'm about to think, is it necessary to have new assessment pains and comfort strategies for these types of patients? Because if we wanted to prevent adverse events, not only are we going to have a prenatal asphyxia, but also the intra-hospital management that we provide, and also the clinical challenge by the nursing team despite continuous monitoring. It's the pain in the therapeutic hypothermia. How do we manage pain? We do know that the behavioral responses are reduced if the patient is intubated. If they're sedated, the responses are going to stop. That's why we need to have an adequate monitoring of pain and comfort. It's important in between the safe first line with non-pharmacological alternatives, but because the pharmacokinetics vary during the therapeutic hypothermia, we have oral solutions. If the stability of the neonate is adequate, we can see physical contention. And this not only happen, only thinking about the parents, because at the end we're going to talk about the parents, and also environmental elements and the therapeutical massage, the participation of the parents. It's very important. And in the systematic review, that we can see that the parents misinterpret tremors as acute pain, and we can see the education of the parents. It's important. What do we do? And I think that it's important to insist on the guidelines, because there is a guideline for all the organs that are involved when the patient has HIE. In nephrology, we focused on three important aspects. First, it's the volume control. Remember when we had a patient with an acute kidney lesions, we wanted to have an hypervolemic patient with high volume, because this is something that was going to allow us to manage the lesion, especially the context of hypoxia, which is the physiopathology of the disease. The review that was done to be able to generate the guideline told us that to have hydrated patients is what we should do, both hypervolemia or hypovolemia. it's harmful for the kidney, and that's why this is going to mean that's going to be more hemodynamic involvement of our patient, and that's why the neurological involvement is going to be higher. Something for the guideline, it's that volume control between 40, 60 per kilo per day, and this needs to be adjusted both in the diuresis and the symptoms of a patient, that it's being hydrated, things that can be due at all care levels, and that doesn't represent any cutting edge technology or anything. We cannot restrict sodium, because we know that within the acute kidney, we have these patients have a physiological effect that the hormone does in the tubule that increases sodium retention. That's why we cannot restrict sodium, and we need to preserve a metabolic stability. This is the nephrologic protection shield. All patients, and this is something that talking about when we talk HIE, but this is something that can apply for all the patients that we have that have a kidney lesion. They all need to have a pharmacokinetic adjustment of the medications. We know that NeoFast is one of the tools that you use to calculate the medications, and it's well adjusted for the patients based on kidney involvement and age. And we need to try to avoid nephrotoxic medications that are not going to change the outcome of the patients. What we talked about, the stability and inadequate volume control, we need to initiate a hormonal replacement theory in this one with peritoneal dialysis, but we also know that technologies have changed. In my hospital and in several institutions in the city, we have carpe diem to be able to initiate the replacement therapy, but peritoneal it's more friendly in those patients when there is a suspicion of a kidney lesion that persists, a creatinine that doesn't improve despite the GUTA protocol that has been mentioned. We can think that there can be an OPSA associated to a malformation of the urinary pathways. This is this table. Be careful. We can see that the water balance, the control of the diuresis of these patients, the control of the kidney function, and the metabolic area that shows that it's not just the frequency of the expected value, but also the observations that we need to take into account when doing a comprehensive management from the kidney perspective. Coming slide. Now we're going to talk about the follow-up, and this is a very ample topic, but we're going to leave some very practical tips, and especially to use the resources in an adequate manner. And when we take into account these three perspectives, I think that the follow-up it's going to start since the moment of diagnosis. We do note that there are scales that have a direct impact during the first 6 hours. But what is the problem that we have, as we can see on the guideline? And when we ask the units that had neuroimages that had hypothermia, and we can see that 80% of the units had brain ultrasound, and you know how many had MRI? What percentage? 1%. 1% had MRIs, and that's why the question is, and also why don't we do a brain ultrasound, which is what we have? This is a question that we leave it to the radiologist. And as a neonatologist, as neurologist in the NICU, we should be able to know how to do a brain ultrasound. We should know this. Here we have two sides of the stories. Here we have the ANIC scale, which is the brain ultrasound, that I'm not going to talk about this. I'm just going to talk about in the afternoon in the ultrasound workshop. What we need to be aware that the ANIC scale helps me to identify patients with a higher HIE severity. When I see the 4 columns, when I see the hamburger sign, that we'll see it later on, we can see that this means that the prognosis is not good. These two scales, these two tables, the ANIN and the MRI, I'm talking about 2 patients that it can be done between 3 and 7 days after the hypothermia. And definitely, what the best thing to be assertive, to be able, it's the MRI. It's the most prognostic tool, so this should be the gold standard. And I can classify my white matter as a mild, moderate, severe, and my central lesion in mild, moderate, and severe. In this table that I'm not going to delve into, I'm trying to make a summary of the prognosis. And for example, I can give you a very simple event. You are going to see a severe white matter lesion when I have bilateral, extensive, and symmetric that involve more than one lobe. Even if I have that, I only have I only have a 20% risk of brain palsy. There's 80% that is not going to have it. And why do I say this? Because we normally do something that I don't like as a neurologist pediatrician, that we try to justify certain things. And why does it mean that the baby arrives and you say, ma'am, I have seen babies with very extensive lesions that are perfectly well? Of course, because this means that we're not understanding the physiopathology. Because I can have a central, well-established central lesion in the posterior arm of the anterior capsule into the pyramidal pathway, and the small, regardless if if it's small, it's going to create a spastic quadriparesis, but that's physiology. To be assertive, if we want to be assertive, we need to know the tools as a part of being able to deliver a prognosis. But we have a problem in Latin America, and for me, it's that we have to be honest, number one. And this is something that I can see the big problem. It's that we need to be multidisciplinary. I think that in Latin America we are multidisciplinary. It's that we see things from different specialties in a parallel manner, but we don't see it in that interdisciplinary way, and we don't want to get all to the same point. And I'm going to set you an example. I just saw a kid that had the post-op of a Rastelli, and he was telling me that the kid was born in the Prenatology Institute. Sorry, the mother was in the prenatology. They take him into the cardiology institute. They separate the mother from the baby, and they send back the mother to the prenatology, and the baby remains in the cardiology. This is not to be interdisciplinary. That's being multidisciplinary, because that baby should be taken care of and should have a follow-up in the institution where it's going to be delivered. At the end, the baby had to travel to my city so that I could have a follow-up. And that's why we are multidisciplinary, but we're not interdisciplinary. And maybe you say, okay, you have to need to the 5th floor to neuro, and then you go to the 3rd floor for nephro, and then you're going to go to the 2nd floor so the rehab checks it out. Very good. And to finish off, what are the 2 challenges that we have? What are the 2 barriers that we have as a country? First, it's our religious beliefs. And I know that San Juditas is going to help, and everything is going to be okay. It's very difficult to adapt to things, and something that influences a lot in our countries. It's la comadre, the mother, the friend that knows more than the doctors, and is going to give advice so that the baby is okay, and that's a challenge.
So to give the floor to Dr. René and the questions, how can we see in the care focused on family, thinking about the follow-up of that newborn once it comes out of the neo ward, from the beginning of hospitalization to educate for the discharge, not only when that newborn is right now, but also thinking if that newborn is going to be discharged with his family, how is he going to go home, all the care dedicated to neurodevelopment is very important. If the baby is stable, if it can be really in the arms of their parents, can we have care focused on the development and in preterm babies? Also, tube babies. It's important because the newborn with HIE can generate also care dedicated to the development. As Dr. Cesar said, the communication is very important among the different professionals as well as the parents and to say, okay, what is HIE? Do you know what it is? Was therapeutic hyperthemia? What are we going to do with your baby? Because the parents are expecting a newborn that is very, that's okay, has this episode, interpartum, and then they see their little baby in tubes, in an incubator. So it's important to explain to the parents in the context, there are certain contexts, because many parents are in shock right now and thinking about what Dr. Sergio was saying. The first thing that they go to the ward is the parents. So the parents arrive without happening what's going on, what's not happening to the wife, to the baby. So we need to have an open communication. It's very important, and also preparing for the discharge, also understanding what are the impacts that this baby will take home. This is very important to consider, that these parents must be prepared for that baby that was born that moment, but not for the baby that ideally was born without any problems. So we need to have a multidisciplinary teams, not the multidisciplinary team, interdisciplinary teams. And this is very important. And not only the doctor, the nurse, psychologist, because these parents have much more prevalence, prone to depression, stress, post-traumatic stress, and they are in a moment in time they did not believe it would happen. So this is also important from the nursing point of view, how to promote this interdisciplinary process, speaking with the doctor, the perinatal psychologist, and to be able to speak among the whole team to create an objective, which the objective is the newborn baby and the family. And regarding the kidney aspects, anybody can follow up these babies. So the idea is to empower the doctors in these processes. What do we need basically to get to know how we must follow this baby? And the guidelines say so. This is the algorithm. You can see it is a medical appointment, 1, 6, and 12 months, with each of the tests, weight, height, and all the clinical signs that we assess in all the patients. Nothing out of the ordinary. And what we seek is to empower with this guideline the primary care doctors. There's also, if there's any alteration in the test, or maybe it's a patient that has a different risk, and maybe we're going to talk about that tomorrow. We would like to invite you to include in this panel, where we're going to not only talk about preterm babies, but all the pathologies that accompany this context. This is what we need to do. Then it's referred to the nephrologist. 1 year to 5 years each year, they have to go to a medical appointment and assessment until 18 years. As you can see, this is nothing out of the ordinary. No strange machines or nothing that we cannot guarantee a follow-up in the kidney. So this is what we do with this activity. We would like to wrap up with this phrase that I really love, because this is Alcepneo is this, and the guideline seeks this, the power of working in a network with the conviction that this is going to strengthen the community and promote our capacities. It's offered to any newborn, offering the best possible outcomes to each baby. Through this QR code, you can download this guideline, and then we can open for any questions. And thank you very much for your attention. Thank you very much for being here today. Thank you very much to my co-panelists. Thank you. We have a couple of minutes if anybody wants to ask any question. If anybody in the audience, just raise your hand so you can ask your questions. Thank you. Thank you very much for being part of this event. We are honored to have these panel members. Dr. Cesar, you mentioned something that is real in Latin America, because we are multidisciplinary. The care of our patients is fragmented, and many times it doesn't depend on us that the interdisciplinary team can work together. But what or those who do follow up, we need to invent strategies, create strategies. I hope we could arrive to the interdisciplinary aspect of this, but this is a process, and the insurance company sends them to another place. We cannot do anything about it. What strategies, is my question, have you found to be able to have that communication among the different professionals that take care of these babies? Dr. Macaroni from Argentina shared an experience where they have a book or something like that where the specialists write down, and to make this network very flexible, to create contacts, we're taking care of the same patient. How can we start from the follow-up? Nobody said it was going to be easy, and now we're creating networks. We're building networks or strategies to improve that communication. So it's much more an interdisciplinary care. Thank you very much. The most important thing, what has worked for us in Mexico, is education, training. It's more than 14 years talking about neonatal neurology, and it has been difficult for me. It's difficult with the neurologists and neonatologists, but I think that we have built bridges in communication. I've always said that we should be much more neurologists being the NICU, because it's much more frequent to see the neurologist engaged with the patient in the newborn baby. So this takes time, I know, but I think everything starts with training and information. This is crucial. It's not from one day to the other. This takes decades. It's as difficult as to say to the nurse that opening the NICU is not going to increase the infectious diseases, but I think everything starts with information and education. That is my point of view. Another question? I would like to ask you from the NICU. Sometimes I speak directly where I live. I have been with the kangaroo program for more than 16 years, and what I've seen is the most important barrier that is out there is the selfishness among professionals. It can be Colombia, Argentina, wherever it is, because many times we do not really appreciate the value or the knowledge that this other person has, and we do not want to shed spotlight on that specialist. So this is one of the main obstacles that we have right now, and that's why we are not able to communicate among each other. Nevertheless, I say, okay, this is the newborn, which neuropediatric will take care of that baby. But thanks to God, I live training myself, studying, and I have a question for you. When during the HIE can we start this conversation? Because in the first day one, they put NIRS on the first day. So this is a question from psychology. This is a question for the licensed. One of the things that impacts the parents to see their children in a blanket, they don't want to see him or her, so without giving any response. How can the nurse, who is the first person that has a relationship with that baby, can manage the stress of the parents and to give them peace of mind? And this is some therapeutics. This is nothing bad for your children. Thank you very much for your question. It's a very difficult question to answer, but I'm going to share a clinical case. That happened to me when I was working in Buenos Aires in the Italian hospital. A newborn arrived with asphyxia, and the parents were doctors, pediatricians, and they said, you have to tell us the truth if our baby's not going to have the possibility of survival, and I want you to disconnect the baby and do nothing at all, depending on your answer. So we have people, because one thing is to comment and speak with a parent that doesn't know anything about medicine, doesn't know what's happened to the baby, but to speak with a person that has a lot of knowledge, it's even tougher. Because talking about honesty, the doctor has to be completely honest, as like the nurse. So we explain to the parent what are the strategies needed, what is the hope, the probability of survival, and to open the doors and say, okay, what I said to the parents of my patients, one day at a time, because there are days when that newborn has a very good evolution, and the next day it's being intubated again. So to be able to have an effective communication, and also it's lacking on the part of nursing, not because they don't have the predisposition, but it's a lot of burden because it's associated to giving really a very quick response. Okay, this is your baby, it has this, and that, and I need to go away, and I don't have the time. I think to mechanize, to put it that way, what we need to do is that we need to change that. What you already mentioned in the previous speeches, or in the mind shift. If I'm treating a newborn with a father is completely in shock with what's happening, so to talk from empathy, taking care of father as I wanted to be taken care of if it happened to me. From empathy, honesty, and say, okay, this is what's happening. Your baby suffered this and that, but you can touch the baby, you can speak to your baby, you can be all the time with your baby. Ask him for his name, and also to tell the parents our name, because many times the parents don't know the name of the nurse, who is completely through the whole shift, through 8 hours. And many times the nurses don't know what's the name of the parents. So I think we need to understand what we need to change. I know that I need to make this baby survive, but I also know that I need to promote this relationship of the newborn with the family, and this relationship should be in the NICU, because afterwards it's going to be much more difficult for the father and also for the newborn. From psychology, it's necessary to generate education, trainings to promote this relationship among the newborn baby and the family. Thank you very much to all our panel members and you for your attention. We have more questions, but unfortunately we don't have enough time.